Hi, so it is my pleasure to invite our next speaker, Dr. Rajni Khajuria. She is a PhD CAGC, current affiliations. She is a Director, Clinical Genomics and Scientific Affairs, Progenesis. Was a director at iGenomics. She's done her Human Genetics MSc from GNDU Amritsar. She's a PhD and postdoctorate, having more than 20 years of experience, special interest in pre-implantation genetic testing, genetic counseling, prenatal diagnosis, preconceptional screening, reproductive genetics, and a lot more. She has published and reviewed various peer-reviewed journals, book chapters, and presented in several national and international conferences. She's a founder and honorary member at Indian Rett Syndrome Foundation, Rare Disease Patient Organization. She's also a member of many national and international societies, and she's a certified associate genetic counselor for Board of Genetic Counseling in India. Welcome, Dr. Rajni. Please enlighten us with your talk.
Thank you, Dr. Nisha, for the kind introduction. Indeed, it's my pleasure to be here, and thank you for inviting me for this workshop. I would like to extend my gratitude and congratulations to you and Dr. Pankaj for organizing this basic workshop, which I hope will the audience find very useful, and because it's cover up a lot of interesting topics. With this, I would like to share my screen. One second. Dr. Nisha, can you see my screen?
Yes, we can. We can.
Okay, thank you. So without wasting time, so the topic of my presentation today is PGTM, which is pre-implantation genetic testing for monogenic disorder. I know you all are very much interested to know a lot of, I could see in question and answer, a lot of queries keep coming. So I hope with this presentation, you will be able to have the answer to those queries. So before starting my presentation, I would like to disclose that I have no financial disclosures or conflicts of interest with the presented material. PGT, as we all know, is an evolving technology, and it represents one of the primary advances of assisted reproductive techniques over the past 45 years. PGT was started with the aim to prevent the transmission of pathological genetic condition, to improve the IVF outcomes, and to shorten the time to successful pregnancy. And we also know that application of pre-implantation genetic testing has been increased dramatically in recent years, and PGT itself has undergone several transformations since its inception. So pre-implantation genetic testing, which is a group of genetic tests used to evaluate embryos before the transfer to uterus, can be categorized into three main categories: PGT-A, PGT-SR, and PGT-M. Where PGT-A and PGT-SR, they select chromosomally normal embryo and work on chromosome level. PGT-M select embryos free of genetic diseases and works at the gene level. So what is PGTM? PGTM is a highly specialized genetic test and with a firmly established clinical utility. It is targeted at monogenic diseases and screen the embryos that are at risk to develop serious genetic disease, and gives you an opportunity to select embryo free of disease mutation. So what is the ultimate goal of PGTM? So the ultimate goal is to promote healthy pregnancies by preventing the transmission of monogenic disorders. So when we call monogenic diseases, I know people want to understand what are monogenic diseases. Monogenic diseases are caused by inheritance of a single defective gene. And we know that there are hundreds of different monogenic diseases which are discovered till date, and they are caused by thousands of different genes. But it is very important to understand that most of these monogenic diseases, they are very rare, and only very few are relatively common. So in PGTM, the most important aspect is that we have to review family and medical history of the patient and the partner. And family history should include to explore the ethnic background of the family member. We need to ask that whether they have any known consanguinity, and whether there is any positive family history in the family for the genetic condition. And accordingly, we have to give the opportunity of genetic counseling and carrier screening or other testing as applicable in that particular couple. This slide shows the evolution of pre-implantation genetic testing and the sampling approaches over the time period. As you can see that way back in 1995, FISH, which is fluorescent in situ hybridization technique, was the only technique being used for PGT. And that time we used to call PGT as PGD, pre-implantation genetic diagnosis. And the biopsy which was being done, the sampling approach was blastomere biopsy, which is day 3 biopsy, where we can take one single cell. But this technology and the biopsy technique had its own limitation. And we can only take one cell, which gives you a limited amount of DNA, and can give you a lot of errors during analysis, which can lead to amplification failure and no results. Similarly, the technology of FISH had its limitation that it can only screen limited number of chromosomes, maximum around 12 chromosomes. So that's how it has been evolved to another technologies, where in 2008 to 2012, we got different technologies like array CGH, SNP array, qPCR, and the biopsy also shifted from day 3 biopsy to day 5 or day 6 biopsy, which is also known as blastocyst biopsy or trophectoderm biopsy, where we take a few trophectoderm cell from the outer layer of trophectoderm and we send it to genetic lab for the analysis. And the good thing about this technology is that you can analyze all 24 chromosomes in the test. And then in 2013, these technology again had their own limitations, and we moved to next generation sequencing with blastocyst biopsy. And this version of PGT was known as PGT-A3. And later on in 2016 and 2017, we got another feature added to PGT, which was detection of mosaicism, which was not available in the earlier version of NGS. And very recently, we know that, as everyone is talking about, that we have a non-invasive approach of PGT also, which came into existence in 2018, 2019, with a lot of research paper coming up and a lot of publication coming up. And we know that we can take a spent culture media surrounding the embryo and we can send it for genetic analysis. And it is again used with NGS approach. And but the only problem with this technology is that it is not recommended for clinical utility till now by all the medical societies and guidelines. So it should not be routinely done. Although we know that there are a lot of clients in India which are already offering this technology. So where can we offer PGT-M? PGT-M can be offered to all those patients who are at increased risk of passing on genetic condition or disease to their children, or it can be offered to those couple with personal or family history of monogenic diseases. So in PGT-M, the main indication of diseases are offered to those couple who are carrier or affected with a genetic condition, including autosomal dominant, autosomal recessive, or X-linked condition. Recently only, these were the primary indication for PGT-M a long way back. But recently, now PGT-M is also being offered for hereditary cancer syndromes and HLA matching too. So I will not cover these inheritance pattern in detail, as Dr. Pallavi has explained all of them. I will only brush up a little bit about these indications of PGT-M. So in autosomal recessive disorder, we know that as the couple, both partner are carrier of one defective gene. So they have a possibility and probability of 25% of having an affected child in each pregnancy. And generally in autosomal recessive disorder, the affected children are not seen in each generation. They can skip generations also. And the couple will have 75% probability of having normal children, healthy children. Whereas in autosomal dominant disorder, we know that the person who is carrier of the defective gene is mostly affected himself. And when the affected person marries a healthy partner, they will have a 50% probability of having a affected child in each pregnancy. And in autosomal dominant disorder, it is important to note that you can see the affected pregnancy in each generation. X-linked recessive disorder is another primary indication for PGT-M, and as a name indicate, X-linked disorders are those disorders which are caused by change or mutation on a gene on X chromosome. And another prominent feature of X-linked recessive disorder is that they typically affect only males, and affected males often present in every generation. Carrier females, generally, they are asymptomatic or healthy, but there are publications where there are reports of rarely some carrier female can be affected due to skewed chromosome inactivation, which Dr. B.C. Das already has explained in earlier presentation that what happened in the X chromosome inactivation. And very important feature of X-linked recessive disorder to understand is that an affected male will pass on the carrier status to all his daughters, whereas the female carrier will have 50% of risk of transmitting the gene to their offspring with each pregnancy. Another indication of PGTM is HLA matching. HLA haplotyping or HLA matching of embryo is done to select unaffected embryos that are HLA compatible with couple's affected child so that they can offer a future hematopoietic stem cell transplantation or umbilical stem cell transplantation to the affected child to save the affected kid. HLA typing is usually combined with preimplantation genetic testing for a specific monogenic disorder, which mainly include hemoglobinopathy, solid tumors, immunodeficiency, or immune disorders. We know that there is the chance of finding an unaffected fully HLA matched euploid embryo is very low. And there are a lot of ethical concern and questions related to this technique, which has created argument for and against HLA matching. So it is very important that a comprehensive psychological evaluation should be provided to the parents to ensure that they are not considering the savior siblings only as an instrument to save the affected child. And also another ethical debate on HLA matching is the fate of unaffected non-HLA matched embryo, which is not defined because we know that as the chance is very low, most of the time when the fertility specialists, they are doing this technique, we know we have to create a huge number of embryo to find a possibility of having a normal fully HLA matched embryo. So that's why there is no guideline that what should be done with those embryo which are unaffected and non-HLA matched. So PGTM, many times I receive this query that whether we can do it for every disorder. No, PGT, you may find that PGT patient may come to you and request PGTM for those situations where we have very little or no clinical utility. So we need to advise and counsel the patient accordingly. And it is important to understand that PGTM should not be recommended where a variant of uncertain significance is found because we don't know whether the variant is really associated with the disease or not. And also PGTM is not recommended for the cases where the couple, one of the partner is carrier of autosomal recessive disorder and another partner is healthy, because we know the chance of having a affected child is negligible. And also PGTM should not be offered to those diseases where there is a combination of variant or mutation which are not associated with diseases. Also, it should not be recommended for pseudodeficiency alleles and somatic only variants. So this slide shows the workflow of PGTM, what we do in the whole workflow. So workflow starts with, as I said, the review of personal and family history, and reviewing and asking that whether the patient has a genetic report and find out whether PGTM is feasible for the couple or not. And once we assess that PGTM can be offered to that particular familial mutation present in the family, the couple should be offered a pre-test genetic counseling where the couple should be advised about the purpose of the test, the benefits, the risks, and the limitation of the test, so that couple is completely understood about the whole scenario and is not having any further queries. So we need to answer each and every query of the patient. And once the patient agrees and gives a consent, we go with a preclinical workup where we need to define or we need to make a probe, customized probe related to that particular familial mutation, which is present in the family. And then once the preclinical workup is done, and we give a go ahead to the fertility specialist that as the workup is done and successful, you can go ahead and start an IVF cycle and do the blastocyst biopsy. And then once the blastocyst biopsy is done, few trophectoderm cells are collected, and these are sent on customized some PGTM kits which are received from the genetic laboratory. And then the center will send this kit to the genetic laboratory where they will do the PGTM analysis and will find out that whether the embryo has familial mutation or not. And then once the analysis is completed, a report will be sent to healthcare professional, not to the patient, because most of the time the lab are direct to the clinics, not to the patient. And once the healthcare professional receive the report, it is recommended that the post-test genetic counseling should be planned, so that the patient should be clarified with all the questions related to their results, related to the implication of the test result for them. And once they understand all of this, the patient, along with the help of their fertility specialist, they can select and transfer the unaffected embryo. So sample requirements. So in preclinical workup, which is also known as pre-PGT-M, mostly the labs will require EDTA blood sample, around 2 to 3 ml blood sample, or some lab may advise you to send buccal swab from couple, affected child, or family member. Sample information or what samples are required can change from lab to lab. Some lab may request you a lot of samples, but some may not request you a lot of sample based on what type of strategy they are using for their preclinical workup. In PGTM, as I explained earlier, blastocyst biopsy is preferred, where 5 to 10 trophectoderm cells are taken and sent to the genetic laboratory. So what is the preclinical workup or pre-PGTM workup? Because this is again a very common kind of a query comes up, that what is it, why it is done, why we cannot analyze the embryo directly for finding that mutation, why you are putting a lot of charges to the patient for doing this pre-PGT workup beforehand. So pre-PGT workup is a mandatory preliminary analysis before PGTM. And the aim for pre-PGT is to confirm that whether PGTM is feasible or not, because many times there can be scenarios where you may send this pre-PGTM is started, and lab may come back to you stating that they are unable to find that particular familial mutation, which the fertility specialist has shared with the lab, and they doubt that there is either the mutation identified is not correct or something else is there, and there can be probability where you need to reject the lab need to reject the PGTM case. So that's why it is very important that this preclinical analysis has to be done beforehand. And pre-PGTM determines the best testing strategy which can be used to test the embryos. And as I said, it has to be performed before the IVF cycle begins. And pre-PGTM is used to develop, optimize, and validate the test-specific probes which we are going to use for familial mutation. So that means in each pre-PGTM, we are using a customized probe for each familial mutation for every couple. Pre-PGTM should be performed under stringent condition using highly skilled staff who is knowledgeable about these technology and have a very good understanding about the quality and stringency. And pre-PGTM evaluate, when we do the pre-PGTM, we evaluate whether there are any amplification efficiency errors or allele dropout rate errors when all primers are being used. So basically, the pre-PGTM is used for verifying the mutation and informativeness of polymorphic marker, which are going to be used for the testing. So what is the aim of pre-PGTM is to ensure that you are getting most reliable results, and also whether they will there should be a minimal chance of misdiagnosis or amplification failures, so that you can get a highly accurate results. As we know that there are other categories of PGT like PGT-A and SR, but it is very important to understand that PGTM is a complex form of PGT. It is not that easy to define like PGT-A and PGT-SR. The approach used in PGT-A and SR are very simple. And whereas in PGTM, you have to establish a diagnosis, which is always not straightforward. And the criteria which is used to select embryos after pre-PGTM or using the PCR for analyzing the PCR result is most of the time will be different for different labs. And it is recommended that we should have at least 2 genotypes for providing an efficient and accurate diagnosis of an embryo. This is a slide where showing you the testing strategies which are being applied for the diagnosis of embryo in PGTM. This recommendation comes from ASHRAE. They define that as per ASHRAE, they have defined that there are three primary testing strategies which should be used by the genetic laboratory. The first strategy is the targeted amplification of informative marker using pathogenic mutation or without it, using a multiplex PCR. But the drawback of this particular technique is that it is very time consuming. It may have a higher TAT and it is labor intensive. And also another drawback is that every time when you have a new gene or locus or a new mutation, you have to develop and validate each and every new mutation using multiplex PCR. The second strategy, which is mostly used by genetic laboratory, is whole genome amplification followed by targeted amplification of informative marker using multiplex PCR. Although this follows a targeted approach, we know that it will not provide a comprehensive review of genome. So it also has its own limitations. And the third strategy which is used by genetic laboratories, whole genome amplification, followed by generic testing using SNP array or next generation sequencing. We know that SNP array and next generation sequencing, they allow genome-wide haplotyping and as well as copy number variation detection. But SNP array is restricted by a fixed number of probes included on the platform of choice. And whereas next generation sequencing is more or less comprehensive, depending upon genome coverage, SNP density, and depth of sequencing. So there are multiple factors which apply to these techniques based on how efficient or what is the sensitivity you need for providing the results. So out of this, next generation sequencing is considered as a more better approach because it is a high throughput approach, allows automation, reduces hands-on time and minimizes the possibility of human error. But again, as per the recommendation, most common strategy which is being used by labs is the excuse me. Yeah, the most common application or strategy which is being used in lab is targeted amplification using multiplex PCR, as it provides you a better accuracy rate. In PGTM results, you may find different results based on different genetic laboratories.
Dr. Rajni, a gentle reminder.
Yeah, sorry. I will be quick. So PGTM result can be identified by the labs based on they can define the nomenclature differently in their labs. The embryos can be defined as affected, unaffected carriers or normal non-carriers. So unaffected embryos will be suitable for transfer after genetic counseling. And another question is most frequently we encounter is that whether PGTM and PGTA can be done together. Yes, it can be done together in a single biopsy where you can have you can screen chromosomal health of embryo and also you can know the genetic conditions in the embryo. So this is the dummy reports which are given in PGTM test results. So on the first table, it shows a result only exclusively for PGTM. As you can see that, as highlighted in red, this dummy couple had 4 embryos, out of which 2 were found as unaffected and suitable for transfer. The second table shows a combination of PGTM and PGTA results. As you can see that after PGTA is combined with PGTM, this dummy couple had only one option, as another one is found to be aneuploid after including PGTA testing. So the couple is left with the one option of having an unaffected euploid embryo transfer. So PGTM has multiple benefits that it can identify genetic abnormality in embryos before transfer and help the couple build a healthy family. Another important benefit of PGTM is that as it is done before the pregnancy is established, it helps to avoid difficult decisions and situations like termination of pregnancy. PGTM also comes with challenges where the greatest challenge we face that low amount of input DNA. So it demands sensitive DNA amplification techniques. and because the low DNA quality can compromise the reliability of diagnostic results. And as I said earlier, that there can be a small probability that test can come as inconclusive due to lack of information marker or failure to detect the mutation of interest. Limitations of PGTM. PGTM, the most common limitation is that you have to get the review done by a genetic expert. It is must to accommodate a genetic expert in your workflow. All genetic diseases are not caused by mutation in single gene, so they cannot be tested by PGTM. PGTM does not test for all single gene disorder in the single test, so it will only test that particular mutation identified in the couple. It does not provide 100% guarantee of a healthy baby, and it cannot be offered where disease is unknown or mutation is unidentified. It also does not eliminate the risk of miscarriage, death, or birth of child with abnormalities. And it also has, like any other technical limitation of contamination, which can cause misdiagnosis. And another limitation of PGTM is that once the couple is pregnant, the lady is pregnant with PGTM, it is recommended that you prenatal diagnostic testing using CVS or amniocentesis to confirm the finding. So with this, I would like to end with these key takeaways that PGTM is a highly specialized test with highly accurate results when offered following the right ethical approach. It helps the couple avoid a miscarriage and prevent the birth of a child with disorders. PGTM should be offered only when there is a significant reproductive risk is identified, and acceptance of PGTM by patient should be optional. Should not be, we should not force the patient to take the PGTM. Increased as we know that it is being increasingly used in IVF industry. It demands that the obstetric care professional, they become familiar with the test benefits and limitation, and they should keep themselves up to date with the practice guidelines so that they can offer the test on the right indication. It also demands a multidisciplinary team approach of reproductive care of the couple to allow them to make informed decision. And most important aspect in PGT is that reproductive counseling in fertility care centers and pre-test and post-test genetic counseling using a genetic expert is important and mandatory and should be an integral part of the workflow. With this, I would like to say thank you. And I will be very happy if you have any queries to discuss or anything to answer.
So Rajni, we do have a lot of queries and we do have a lot of questions and we want you here for a very long time. But the thing is that the time is the only thing which we don't have.
I
So
know,
what I suggest is we can postpone it for a little bit. We have our next speaker waiting for her talk. And
Yes,
after that, we will talk about, uh, we will take the question answers.
sure,
So
sure, Dr. Nisha.
thank you so much.
Thank you so much.
Please wait for some time so that our participants can ask you questions. Mohit,
Sure,
can I have
sure.
the TV, please?